Anomalous left coronary artery that arises from RCA with intramural segment, interarterial course, it is having highest chances of sudden cardiac death. Basically, it's challenging, time-consuming, good radiation exposure, contrast exposure, and it requires a lot of equipments too. Even more challenging is in the setting of primary PCI. So basically, these are the four types. Absent left trunk, very commonly encountered. Anomalous origin of RCA from left sinus. Third is anomalous origin of Lcx from right sinus. And last is anomalous origin of left coronary from the right sinus. Whenever we encountered, usually the first step is rather than hunting the anomalous origin with a series of standard shaped selective diagnostic cath, better is to do a high quality deep aortic root angiogram in AP and lateral view and keep it as a reference point and then begin identification process with the most appropriate catheter shape. And when you have a high degree of suspicion, better to go directly with a CT coronary angiogram. So this is the most common one, easy to handle. Just take a half size smaller catheter. It will automatically engage into L6, give a counterclockwise maneuver. The catheter tip will shift anteriorly and it will easily engage LED. These are the most toughest to deal with and more complicated ones. Most common one is when it is just in the RCS, just to the side of left coronary catheter with a pinpoint ostium and it traverses horizontally across the aorta. Usually it is usually we can engage it with a AL2. Rest Lea catheter, which is a modified AL2. Rest are when it is below or above. It is in the sinotubular junction. These are usually handled with AL2. Sometimes we require specialty catheter while doing PTCA, like right anomalous coronary artery opposite side launcher catheter. Then sometimes it is in the right sinus, but just at junction of right and left commissure. Usually they are also handled very well with Emplarzer. Sometimes when it is associated with tortuosity, we require special catheters like Sherpa-NX balanced. So this is here example where we encountered it with the help of Emplarzer left. It is arising just adjacent to the left coronary artery. This is like right anomalous catheter from launcher guide cath. This is helpful while doing the PTCA. So figure 1 is important. Basically, sometimes we have a non-selective engagement of this anomalous artery. What we can do, we can put a wire inside, then we can take a guide liner so that we can complete our procedures. These are like, this is a good example where we use the Sherpa-NX. Sherpa-NX is having multiple curves, even its shaft is also bent. So when you are encountering anomalous RCA with tortuosity, it's a good option. It fits into the aorta very well. Now that was a theoretical approach. This is a more practical approach. When we are encountering such cases in the cath lab, if it arises just next to LM, use a simple JL. And if it is above the aorta or below, you can use an Emplarzer. If all this procedure fails, one very good method is just engage with the help of a TIG or a diagnostic catheter, put a exchange length wire, then track a 6 French guide cath over the vessel wire. And if you have a specialty guide cath, it's very well. If you don't have, then also we have an option. We can modify our simple guide cath that we have in our lab. So this is the inverted Judkins method. What you do, you take a slightly undersized 6 French 3 through 3.5, loop the 0.035 wire upward in the left sinus, follow the guide cath with a clockwise twist, the catheter inverts and points anteriorly and will hook into the anomalous RCA. And this is how to modify the shape of guide cath. Either you do manually or you took a needle introducer, put it inside, bend it, dip 30 seconds for a hot water, then put it in the cold water, then it will be a long lasting. This is very simple. That is anomalous Lcx from right cusp. It can be simply engaged with the normal right catheter we have. Lastly, anomalous origin of LMCA from right sinus. It can be easily engaged with GR4, hockey stick, whatever catheter you have for the right sinus. Most important is these are the cases where they are mostly malignant, having an intraarterial course, intramural segment, and they are associated with sudden cardiac death. Regarding PTCA, we can do with a simple right-sided catheter. Thank you for your attention.